Please be advised, this video explores sensitive and potentially distressing topics.
This is Star FM with the latest news. Today, a leaked report has criticised doctors at Wexham Park Hospital. Emma Bentley, 16, was found dead having taken ecstasy tablets again. The report concludes that doctors should have stopped her leaving the hospital and going out to a local nightclub to obtain more drugs. Last year, the same hospital allowed a grossly obese patient to put on weight whilst in hospital. Her mother said the hospital was useless and should have stopped her ordering takeaway pizzas. Meanwhile, the mental health watchdog also complained that the number of suicides in the region is unacceptable, reporting that once again the doctors are failing to do their job properly. More on those stories in the news roundup at 10.
Okay, true or false? Only just, wasn't it? Had you going for a bit, though.
Just kind of worried about.
Yes.
Slurries.
So, I think the problem with writing satire or sarcasm is that sometimes it's a very fine line between reality and falsehood. And I think that radio clip, in a way, puts it a little in context, doesn't it? That that's how we feel. I'd like to read you now a piece from a Defence Society, a letter that I received and some of us received. It wasn't written to me personally, I'm glad to say. The dark tunnel in which the profession finds itself appears to have no end. Most doctors to whom I speak are caring, conscientious individuals who just want to get on and provide the best service they can to their patients under sometimes impossible conditions. Yet all one hears about is just how bad doctors are. And a little later on, I'll quote at length, but I think it's worth listening to. One adverse clinical incident can give rise to a complaint, disciplinary action, an inquiry by the Health Service Commissioner, investigation by the General Medical Council, a claim in negligence or other civil proceedings, an investigation by the Commission for Health Improvement, criminal prosecution, a claim for negligence, and a coroner's inquiry. The National Clinical Assessment Authority and the National Patient Safety Authority may also become involved. Now, I read that at length because I think it does do some scene setting about the notion of a blame culture, and where more relevant than when we're thinking about suicide. It's got to be somebody's fault. Let's blame the doctor. Okay, so when we think about suicide, it's worth appreciating that there are a number of related matters. There's attempted suicide, suicide itself, deliberate self-harm, and also an important aspect, non-psychiatric reasons. And what I'm wanting to do now is really just to concentrate on suicide, but it's actually worth remembering, of course, that you need to see these things in context. Here's another letter of criticism, this time from the Department of Health. In this report, they summarise annual rate of suicide. Do you know what the annual rate of suicide is?
11.1.
Yeah, it's about 1 per 10,000, male to female. What's the, what the statistics are? Of suicide.
About 3:1.
Yeah, that's right. So 3 male to 1 female. Okay. And how does that differ from deliberate self-harm?
Deliberate self-harm is more in females compared to males. But I don't know the exact rate.
Yeah. What about methods? What do we know about methods? What are the most common methods for suicide?
In female, overdose, and in man, more hanging and bullets and gunshot.
Yeah. Hanging and jumping account for about 50% of suicides, and paracetamol overdose about 10%. The report found that social adversity and isolation were important factors, which I guess comes as no surprise. And another figure worth remembering is that 75% of people are not in contact with the service. So, there's a large number of people who just don't see at all. So thus the average general practitioner will see 1 to 2 per year, and current treatment strategies fail to reduce suicides. Since the introduction of antidepressants, there's actually not been any impact on the rates. Often people aren't adequately treated. It's important to remember that serious mental illness is associated with a quite sinister outcome. A figure of 20% is often quoted. Thus, even if you're aware of it, intervening effectively is sometimes not possible. In spite of constant nursing supervision, patients can and do hang themselves and jump out of windows, and do so whilst in hospital. It's even harder when in the community, as the following example will show.
Well, that's when I jumped, wasn't it?
What do you think's wrong with you?
What I think was all wrong with me? Well, I suppose I'm depressed. Well, when I jumped, yes, and I hurt my foot and my leg and my arm.
But why did you do that?
I don't really know. I must have been fed up or something.
Was there anything going on in your head? Was there perhaps a voice telling you to jump?
I don't think so.
Have there been times that you've felt so depressed that life's not been worth living?
No, I don't really think so. Even when I jumped, I don't think so.
So you didn't jump because you were depressed? So why do you think you did jump?
Don't really know. I mean, it just came over me.
What just came over you?
To jump.
Now, how did that notion come into your head?
I don't really know.
How do you see the future now?
I see it all right.
I mean, do you think you're likely to do anything that might be dangerous to yourself again?
No, I shouldn't think so.
You've said that before.
Yes, but this is really hurting me. I mean, my foot's really hurting me. So, it's coming back on me, isn't it?
When was the last time you felt suicidal?
A long time ago now.
Weeks or months?
Or weeks.
Okay. What do you understand of your difficulties now?
My difficulties?
Your illness, how do you see it?
Well, it's getting better.
Do you think you've been ill?
Oh, yes.
What do you think's been wrong with you?
Depression.
In the past, it's been very difficult to find ways of helping her, but it seems that really the last few months things have been perhaps a bit better.
Yeah.
What do you put that down to?
Well, I suppose she's trying to try a bit more than what she was before.
Yes.
And now she wants, before, she didn't used to want to go out, and now you got a job to keep her in.
Right.
You know, she wants to go out, and which I think is good. If she mixes with more people, the better it is for her.
We go to the pub
How often?
only once a week.
Uh-huh.
And we go to the community centre.
Yeah.
But she hasn't been getting up to go to the day hospital. Got her bag all packed to play badminton or swimming, wasn't it?
Yes.
Monday, and you never went. Why didn't you want to go? Why didn't you want to go? Why didn't you want to go?
So would anyone like to make a stab at what they felt might be the diagnosis on the limited information you've seen? Or what might be the differential diagnosis?
Schizophrenia.
The thing is, we don't know about her history, so that when we don't have adequate information, that's a valid differential diagnosis.
If it were a diagnosis of personality disorder, what pointers in the history would you be looking for?
Several attempts in the past, and mostly generally they're not very serious, but and there's usually comorbidity, and there's a pattern of when the differential, when the reasons, usually it's either antisocial or borderline personality that are likely to kill themselves, that sort of thing. They have difficulty in having relationships and emotionally unstable, a sense of emptiness, sense of abandonment.
We want to know more about the childhood period.
Right. When you say a bit more about the childhood, tell me a bit more about that.
If there is any childhood difficulties, family disharmony, some sort of sexual or physical abuse, that could be a triggering factor of being having this.
What would be the pointers to be looking for if you felt that she had a, say, a psychotic depression? What would you be looking for in the history there?
Previous history of depressive episode, and also sort of biological symptoms, physical symptoms of depression, and how her mood varies, and perhaps precipitating things that might have been going on in her life before an episode of decrease in mood. I also thought that she had physically looked pretty depressed. She had furrowed brow, her eyes were frowning, she had a very blank looking face, very reduced blink rate, and appeared quite psychomotor retarded, especially soon after the first attempt.
Okay. So let's move on to the management. What would be the guiding principles? How would you manage somebody like this?
Well, you want to start with sort of medical management, and then go on to psychological and then psychosocial factors that one could moderate. Medical, obviously, if you felt, as everybody seems to be saying, sort of a depressive element to it, then you've got to start with antidepressants and
take them to a right dose, sort of a dose that is not minimal, like that sometimes happens, so that I can see whether it's working or not. And then you might want to add, because there is a suspicion of it being a psychotic depression, and adding an antipsychotic might help. If I have a feeling somehow, I mean, I'm kind of feeling that behind, I wouldn't have thought that this was just purely a depressive thing. It might be, in my view, a bit more bipolar than unipolar. There's no clear-cut evidence yet, but I mean, I would be sort of looking for that. If that was the case, a mood stabilizer would help. And that's as far as the medical management goes. Psychological, obviously, things like CBT might help. Other psychological treatments, just plain very low-grade, supportive counselling type of thing might help, depending on her insight. Compliance therapy, things like that might help to make sure she understands why she's taking and what she needs to be doing to help herself. And then social factors like isolation and other things that need to be sorted out. If there are family problems, marital problems, they're likely to aggravate or at least maintain the illness. So those need to be helped with, really.
So couple therapy, I mean, the husband seemed as if he doesn't actually understand why she's not doing what she was required to do, why she's not going to the clubs or the swimming. It seems that he needed some education as well, that it might be actually her illness that contributes to these kind of symptoms of behaviour.
I always felt there was something about the relationship between the two of them, but I couldn't get anywhere with it. My feeling was that she probably had a psychotic illness. I think she's the wrong age and didn't have any of the sort of predisposing factors with regards to personality disorder. She'd tried to set fire to herself. She'd poured caustic over herself, and she'd jumped from windows on numerous occasions. So I think there's a sort of an inevitable pattern there. But in terms of sort of frank depressive symptoms or any sort of frank psychotic symptoms, never really got a convincing history, but I think we always got the feeling that she wasn't quite right. What would you want to say to, the community nurse who was looking after her?
In case of the community psychiatric nurse, I think they will need to monitor the mental state regularly, maybe say weekly or once every 2 weeks, to know exactly if she's deteriorating. Right, it does mean she needs possibly to be admitted, treated as inpatient.
And that brings an important issue of care program approach, multidisciplinary approach as well. So that has to be organized quite sooner than later, and everything has to be put in place so that each person knows what their role is when such incidents occur, so that there's no loss of communication. So obviously appointing a key worker if she doesn't have one, and monitoring the situation, plus also regular outpatient follow-up, and monitoring her medication, supervision by the husband or the CPN.
Okay, let's move on. One of the most frustrating times professionally is the rehabilitation phase of any illness. But for the patient, they see it differently. The future appears bleak and the hurdles overwhelming. Whether that is more painful surgery, plastics and burns especially, or chemotherapy. For the schizophrenic, it may be the first time they realise the implications of their condition. The same is true for the addict. Being sober isn't much fun.
I'll start cutting, and I didn't feel faint at all. I didn't feel sleepy at all, nothing. So I got the razor blade and I had a jolly good go at my wrist, left and then right, and they started spurting blood and everything. And I knew from people before that had done it that the blood is inclined to clot. So I kept rubbing it with the flannel, and then I still wasn't feeling as though I was going to pass out at all. So I then did it to my elbows. I thought, well, the arteries are... I'm an ex-physio. I thought the arteries are bigger in the elbow than they are in the wrist, so I did the elbows. And they bled profusely for a time, and then stopped, and then I thought, well, I'll try the ankles. So I did the same to the ankles, and I don't know how long I was there. I mean, I was certainly compos mentis, and then I thought, well, the only thing to do now is to cut my throat, and surely that'll kill me. And so I stood up in the bath, slightly unsteadily, because I suppose I'd lost a lot of blood. And I looked in the mirror, and which was facing me, and I sort of did that to my neck, you know, to see where the arteries were. And I took the razor blade to them. And it's extremely hard work cutting your neck with a razor blade. And that didn't work. And then I thought, well, the only thing to do is to sort of stab myself in the heart. So I wrapped a few things around my wrist so not to make a mess on the carpet. I'd put towels all down so it wouldn't make any blood and things, and the kitchen floor's quite easy to clean. I got a knife out there. Our knives aren't very sharp, unfortunately. And I really, with all my strength, you know, went to where I thought my heart would be. And it's just no impression at all. However, I did feel a terrific guilt feeling, really for my sons and family, and for the AA system, you know, all these clever dicks that have gone 20 years without a drink, you know, and all this sort of thing. And how well they said I was doing, but in fact I've been absolutely bored stiff, and I haven't enjoyed my sobriety one bit. It's been torture. I wasn't feeling fit enough to have an affair, if you understand. Sort of, I thought it's too much trouble, too much, you know, you've got to go out and buy a wardrobe of clothes, and, you know, because he's quite a go-getter and he goes abroad a lot, and he wanted me to go abroad with him and things, and I just thought, I really don't want to live any longer. I enjoyed my life until I until I retired, I suppose. More or less. Certainly until I was 40, I had an absolute ball. I worked all over the world. I've been all over the world, either on holiday or working. And so I've been everywhere, seen everything, done everything. My sight is getting bad. I keep having to go to the opticians, and, you know, and my memory's totally gone, and my hearing's a bit off, and everything's becoming more difficult. I hate the village. I hate where I live. On the other hand, if I move up to Derbyshire, where I came from originally, I get a little cottage there or something. I'm still going to be on my own. I don't want to be on my own. And quite honestly, I don't want to get any older. I don't think I'm one of these people that was built for old age. You know, I can't accept it gracefully, like a lot of people can. I mean, a lot of people, I mean, they really fight for survival. There's one man that goes to AA. He's had 3 tumours. I think they're cancerous on the brain. He's had a whole lot of surgery. His leg's gone, and he still soldiers on, going to AA, and, you know. And to me, if that was me, I would do something about it and hurry up the process. You know, I couldn't live like that. And I just feel that I don't know why people think life is so good. I get absolutely fed up going around Tesco's thinking what to eat and the laundry and, you know, and I just feel... I don't. I try not to think about it. I just wish I could die in my sleep, basically. Or have a heart attack or something, you know. And just go.
What's your immediate reactions to that?
Chronic dysthymia, it appeared.
Okay.
With substance alcohol abuse.
Right. Tell me, you've mentioned chronic dysthymia, so what's that?
They don't have the biological features of depression very clearly, and they don't satisfy the depressive ICD category of depression.
I mean, would you think that's a personality disorder or an illness? What's a useful way of looking at that?
Previously it was called depressive personality disorder. Now it's placed as chronic, as dysthymic disorder.
Is it part of depressive
symptoms? Yeah,
part of the depressive disorder.
She has a very low coping strategies. That means she can't really cope herself with life. As she said, I mean, every day she's thinking, going to Tesco, just thinking about the laundry, what she eats. I mean, her thinking about the life activities is still very low too. Yeah, I agree with Dr. Muthalago. She's chronic dysthymia.
If she has a chronic dysthymic disorder, I think it was on top of a kind of a dependent personality. Once her role was finished, she was retired, children grown up, being left on her own, she couldn't function. And she couldn't see any future after that. And the only dependency that she could get, it was the alcohol probably. She seemed very dependent, inadequate kind of personality.
Yeah.
I think that's also, I mean, we might sort of ignore it because we're looking at it from like a medical point of view, but if you think of it, it could be seen as her philosophy of life. I mean, she's a bit like somebody who say for euthanasia, whereas lots of people are not. For her, she, as she said, she doesn't like being old. For her, she was very hedonistic by the looks of it, went all around the world, did lots of things, lived a quite full life when she managed it. And now that her faculties are deteriorating, her sight is gone a little bit, her hearing, and she can see these things going downhill probably faster than she wants. For her, it seems that, she can't kind of see how she could cope with living that way when she's got a philosophy that says, I've had my life, I've lived it well, and I don't want to sort of go piecemeal, let's say. After all, I mean, that is also part of, the philosophy of life matters. Each individual has their own philosophy of life to some extent, and we've got to respect that in a way. I don't know if it's a bit sacrilegious saying that, being psychiatrist.
I wonder if, I don't know her age, but if she's having any form of a dementia illness, because she did mention that her memory is failing, and probably she has an insight, so she realized that day in and day out she's finding it difficult to cope, and that is actually triggering some of these problems.
Yeah. There's a few points, I think, against dementia diagnosis. First, that the insight, and also she was doing well until she became retired. She felt like nothing left for her. She could talk about her previous life, and she did not look at good insight, and she's not like somebody like demented. Usually people with dementia, they don't feel like they to kill themselves, and they don't make them like, oh, there's nothing left for me. My memory is gone. I want to kill myself. Usually they don't care about, usually people with depressive, severe depression, with pseudo-dementia they call it, they care more about their memory and become frustrated when they lose memory. People with dementia, they don't care, they're not aware, only for very early signs. I think they more care about their memory.
She did say one thing quite clearly though. She said, sobriety doesn't suit me at all. That means that she's had a period of drying out and she's still feeling that way, probably worse, because alcohol might have been boosting her up or
I have a deep feeling that this case, one of the cases, could not be prevented.
Yeah.
Even if you give her ACT or anything that is at the end, because the very simple daily living activities becomes a very burden on her. This means it's too difficult to this case to be prevented. Actually,
this is myth that mental illness could not be treated. I don't agree with this. That I think long time ago, maybe several years ago, or 30, 40 years ago, that there is no treatment for mental illness. But I think the prognosis now we are doing is good. And the myth that this kind of like schizophrenia, dysthymia, severe depression that could not be treated and could not be prevented. I mean, I don't know exactly how she shot herself, but I mean, if you look at the seriousness of her suicide, the wrist and the elbow and the ankle, I think this everything could be prevented. But I'm not saying that 100% could be prevented, but I think we have to say that now there is treatment for mental illness and we always can get something better.
I mean, I think that one of the lessons with her is well worth remembering is that treating addiction is not just simply a matter of detoxing people, and that just simply getting them to be sober it can leave them very exposed and vulnerable to underlying issues, whatever they may be. And I think it's a pitfall that you can easily fall into. That you think how clever we are, we've got her dried out. But actually, in the long run, what have we contributed to her quality of life? Perhaps one of the hardest areas is the overlap between bereavement and depression. Interested really to hear a bit about how you've got on since your husband's died.
Well, that's it. You see, I think, I know now, I must have been depressed for a lot longer than I first thought. But, you see, I came in here on the Saturday night. Well, on the Monday, that was 2 years since he died in Wexham. And I had this thing about Wexham. He was a sick man for a long time, cancer.
Tell me about when your husband died. How did you feel first off?
Well, I think my first words were, God in his mercy gave him grace. He was in such a terrible state. And of course, another thing, for years and years now, I wrote poetry, and I remember in one of the poems, the line I put, I don't seem to have tears for relief. It's all inside. I can't sort of cry properly. It's as if I'm, how can I explain it? It's as if I'm not working properly inside, you know. Difficult to explain. My son and daughter-in-law, the other son, came in and told me about a fellow where my daughter-in-law works. He, 31, came to work, hadn't been there long, and he had terrible pain in his arm. And within about an hour, he was dead. He hadn't got a wife and family. He lived with his mother. But I mean, my first thought was, oh God, I'd have willingly have gone in his place. It seemed so unfair. You know what I mean? Do I sound silly?
In what way is your sleep disturbed?
Well, I can't seem to get any sleep. What I'd call proper sleep. I'm conscious sometimes that I thought one morning, I got thoughts in my head that aren't mine. And then it occurred to me that was probably a funny sort of little dream, you know. For sleep, I don't recognise the sleep. That's the only way I can put it. I mean, in the past, I'd go to bed my husband was always left him, with his television and took my book up to bed. And I've been reading in bed so long as I can remember. And I read the large print because my eyes are not good. But then I got to a point where I thought, oh dear, such an effort to... I was the first year after he died, I managed to read and lose myself in the book. And then suddenly that seemed to go.
You said that you felt that the second anniversary of the bereavement's worse than the first.
I suppose, yes. I suppose so. Though I put a lot of it down to the fact that I was in Wexham, and he died here. He was a lovely man. Lovely man, but we did have a lot of worries to cope with.
Do you miss him a lot?
Yeah. Oh, I do. I do. We were married, well, he died on the 11th of January, and if he'd have lived till 17th of February, we'd have been married 52 years. I first knew him, thank you, when I was 17 and he was 19. We were married the day after his 21st birthday. 3 lovely children. But a lovely life. Sorry. At least you made me release a little bit of emotion, haven't you? That might help me. Do you think?
I hope so.
Perhaps I've kept things bottled up too much, have I?
Do you feel that?
Perhaps I have. But somebody had to carry on. Somebody had to do it. It was only me. And I'm so tired. So tired. I'd love to go home. Obviously, I'd love to be in my own home. I just wish I could feel a bit fitter in myself, But I carried on until I knew I couldn't make it up to the shop to get the cat food. I was so weary. This awful weariness.
How do you see the future now?
Well, as far as I'm concerned, I suppose like that. It's what is there for me on my own?
What's the difference between bereavement and depression? Anyone like to have a stab at that? It's a difficult question.
Bereavement goes through various stages, isn't it? And then the person sort of normalizes after those stages, whereas with depression it doesn't, it just goes downhill, and it doesn't there doesn't seem to be a natural kind of conclusion to it somehow, as happens with bereavement, where you reach the stage of acceptance, and then life carries on.
Okay, bereavement is normally after a loss, and it's low grade, does not meet the ICD-10 classification of depression. It can go on for 6 months, and in older widows it can go on for even over a year.
I think it can be very difficult to tell the difference in the context of bereavement, whether someone has a depressive episode or not, especially for someone like this lady who's had a very long relationship with her husband, and it's such a significant loss for her. And I think one has to think about a depressive illness and think about treating it, but in a way it is understandable for her to still be mourning her loss of her husband 2 years later, and arbitrary saying people should be better after 6 months is probably a little bit unrealistic for some people. For example, this lady who may have what we call atypical depression, bereavement, but actually for her it might be quite reasonable, understandable.
Well, coming back to the same environment where her husband died 2 years ago, when the first anniversary, as you've asked us, seemed to be slightly easier for her to go through rather than the second one. The second one, she was in the same environment, whether the whole anniversary brought all the emotions back, which she was trying to to cope with, and that made it more difficult for her to actually to cope. And it was quite obvious that physically she was not well at all, and it seemed that she had a chronic airway obstructive airway disease. And
there's some differences. I mean, in bereavement, you have this guilt feeling to some extent, that where you think probably you've not done enough to save the person from dying. But in depression, it prolongs, and you get preoccupied, and you blame yourself, and there's delusions of guilt, and you just blame, and you think, instead of thinking, right, yes, the person died, and the person is somewhere, sometimes you feel happy about the person, all right, they've gone, they're free of pain. Whereas here, she feels she should be with the person, or be there with, that's more depression rather than bereavement. It's slipped into depression, although initially it was bereavement. So I think there's some certain differences.
I think it's pretty common, isn't it? Because she was in hospital for a while, and then if you're not careful, you're going to make her feel worse, and you're going to increase the hopelessness, aren't you?
The thing is, they don't have energy to do it properly, and I somehow felt that she wanted more energy to do it properly. That's what she meant. I want to be a little more fitter, not really to get cat food. I thought it was, to actually do something seriously, and I just felt that she was trying to say that.
The most hazardous time, isn't it, is when they're recovering, isn't it? It's on the way up, when they have a bit of energy to do something now. So it's very dangerous. So really, just to recap, I think it's worth remembering that I think there are some cases of suicide that are not preventable, and we've got 3 examples here of rather different underlying causes, but the outcome is the same. And I would suggest that of the 3 examples you've seen, none of them actually are preventable, really. And it's worth bearing in mind that although it's appropriate to have a therapeutic optimism, I think there are some cases that you're not going to win. And I think these 3 examples illustrate some of the features. In fact, some of the linking features are the hopelessness and the social isolation. And I think that then brings us on to what can be done. And the first thing is to appreciate that it can happen when talking to relatives. I think it's realistic to make them aware of the risk that in spite of everything something might go wrong. I think that all this business about risk assessments and so on, whilst that's to be commended, I think if you're not careful, there's an expectation that everything is preventable, and I don't think that's the case. So I think first thing is to recognise that it will happen. I think just to pick up some of the earlier points, there's a lot that psychiatry can do, and I think we need to push for a first-class service. I think we need to have access to skilled psychotherapy of all sorts. I think we need to have ready access to beds as a place of safety. And I think we can all recognise sometimes the clinical decisions have been influenced by the lack of resources. And mostly we get away with it. But inevitably, over a professional lifetime, you're going to come unstuck. So really, in terms of clinically, it's essential to be aware of the high-risk group. And the high-risk group, I think, are those that people are going to be alone, those with a bleak future and a sense of hopelessness from whatever cause. I mean, they might feel that life is hopeless because they're bereaved. They might feel hopeless because they've had treatment that's been partially successful. Or they might feel hopeless that now they're sober, what's the point? Going back to that report, that recent report seemed to suggest that 250 cases in the UK per annum are preventable, and that if there were a community treatment order, that might conceivably prevent 32 cases. There were some practical rules that I think would all go along with that. For high-risk people, there should be a visit at home or an outpatient within 7 days. I think that sounds sort of reasonable. that we should fix the curtain rails so that if people try to hang themselves, the curtain rail collapses. And I think we can all think of many hospitals where that's not the case. The report refers to more plans and goals. Just wait till that starts, okay. The report refers to more plans and goals, but there's not much mentioned about quality service and things like that. And I think that one's got to be realistic about what can be achieved with the resources available. My view, I think, is that inpatient facilities, a period of assessment in hospital, is a prudent and safe option, and it does allow you to make a more reasoned and valued assessment, although even coming to hospital may not prevent it. These three cases had the smell of death, didn't they? When you looked at them, you know, if you've been doing psychiatry for more than a couple of weeks, all those three cases, you just knew that this is bad news. And there is something about something called clinical experience. And I think what you pick up on is the severity of the presenting symptoms, you pick up on the hopelessness, and you pick up on the social isolation. So for those cases, I think everyone recognised they were high risk. And that, in a sense, was why I recorded them, because I knew that they would be high risk and they would be worth following one way or another. Violent, destructive behaviour is always a bad prognostic sign, and I think we all know that. And I think with the bereavement case, I felt that there wasn't much that we could do. I mean, she'd been in hospital for ages and we hadn't achieved anything. So, you know, you don't need to have a crystal ball to work out what's going to happen. You know, we talked about having an optimal service, and I think that that will make an impact. But I think even so, there will be a percentage of patients for all the best you're going to be able to do is to defer the inevitable.